Hey everyone, and welcome to The Explainer. We're skipping the fluff today and jumping straight into an exhaustive postgraduate level review of Chapter 451, Disorders of the Autonomic Nervous System. We are putting on our medical detective hats to investigate something truly incredible, the human body's hidden autopilot. This is the invisible, sprawling network that keeps you alive without you ever having to consciously think about it. But what happens when that autopilot starts to fail? And honestly, how do you even measure a system you can't control? Well, grab your magnifying glass because that's exactly what we're going to solve today.
Here is the roadmap for our investigation. First, the global neurologic burden. Second, the neurologic method. Third, the anatomy of the autopilot. Fourth, testing the invisible system. And finally, number 5, when the autopilot fails. So, to understand why this investigation matters so much, we first need to zoom out and look at the global neurologic burden. Get this, 1 in 3. That is a staggering statistic straight from the World Health Organization. Neurologic disorders affect nearly 1 in 3 individuals globally right now. We aren't just talking about some niche medical issue here. This is literally the leading cause of disability and the second leading cause of death worldwide. And because populations are aging and metabolic risk factors are going up, these numbers, they're expected to double by 2050. The stakes for getting an accurate diagnosis absolutely could not be higher. Now, looking at this breakdown, you see conditions like stroke and Alzheimer's disease taking up huge chunks of that global burden. But here is the real secret of the master diagnostician. Whether you are dealing with a massive stroke, Alzheimer's, or a super subtle failure of the autonomic nervous system, the diagnostic process always begins with the exact same fundamental, rigorous method. Which brings us nicely to Section 2, the neurologic method. Even in an age of incredibly advanced MRI machines and genetic testing, diagnostic errors still happen all the time. And it's usually because there's an over-reliance on technology instead of taking a solid clinical history. The proper approach is a strict 2-step method. Step 1. Where is the lesion? You absolutely have to map the anatomy first. Is it central? Is it peripheral? Spinal cord? By deciding exactly where the lesion is, you immediately limit the possibilities to a manageable number. Only then do you move to step 2. What is the lesion? This where versus what method is absolutely critical. It prevents clinicians from missing treatable diagnoses. Like if a patient has visual blurring and paraparesis, identifying the anatomy as the optic nerve and spinal cord ensures you don't miss highly treatable causes, like a vitamin B12 deficiency. All right, having mastered the general method, let's pivot to Section 3, Anatomy of the Autopilot. Let's apply this method to our specific target. The autonomic nervous system, our internal autopilot, is this massive, sprawling reflex circuit dedicated entirely to securing homeostasis. It has massive central organization, reaching from supratentorial areas like the insular cortex and hypothalamus, all the way down through the brainstem and into the spinal cord's intermediate lateral horns. From there, these thinly myelinated preganglionic fibers project out to peripheral ganglia, and then unmyelinated postganglionic fibers carry the signal out to literally every organ in your body. We generally divide this output into 2 main opposing forces, plus the highly independent third branch called the enteric nervous system, which runs the gut. So the crucial takeaway here is that this system maintains balance through a constant antagonistic push and pull. It's an endless tug of war. On one side, you have the sympathetic system. That's your rapid, urgent fight-or-flight response originating in the thoracolumbar spinal cord. It's primarily adrenergic, meaning its postganglionic neurotransmitter is norepinephrine, which causes things like sudden heart rate spikes and blood vessel constriction. Then, pulling on the other side, is the parasympathetic system, the calm, restorative, rest and digest response. This is a craniosacral system that heavily relies on acetylcholine and muscarinic receptors to slow your heart down and kickstart digestion. And the absolute heavyweight champion of that rest and digest team, the vagus nerve, or cranial nerve 10. Just look at its massive reach here. Its parasympathetic fibers originate up in the dorsal motor nucleus of the vagus and travel all the way down into the chest to decrease your heart rate at the sinoatrial node and promote peristalsis all the way through your GI tract. It's literally the superhighway of the autonomic nervous system. But this brings us to a major clinical challenge in Section 4, testing the invisible system. Seriously, think about it for a second. How do doctors test a system you can't consciously control?
A neurologist can easily ask you to raise your arm to test your motor cortex, right? But I can't ask you to consciously constrict your splanchnic vascular bed or change the electrical rhythm of your heart's pacemaker. To solve this mystery, medical detectives have designed these incredibly ingenious ways to trick the autopilot into revealing its secrets. One of the most elegant clinical assessments is the Valsalva maneuver. It's actually brilliant. A patient blows into a closed mouthpiece to increase their intrathoracic pressure above 40 millimeters of mercury for 15 seconds. This simple act decreases venous return to the heart, which causes a sudden drop in blood pressure. The autopilot immediately senses this emergency. The sympathetic system kicks in, constricting peripheral blood vessels to stop the fall. Then, when the patient finally stops blowing, blood rushes back to the heart, causing this sudden blood pressure overshoot. That overshoot triggers the parasympathetic vagus nerve to aggressively slam the brakes and slow the heart rate down. By mapping these exact beat-to-beat phases, doctors can perfectly isolate both the adrenergic sympathetic function and the vagal parasympathetic baroreflex arms. We are essentially forcing the autopilot into a nosedive just to see how well it corrects the plane.
And this builds out an entire fascinating diagnostic toolkit. Frankly, we put this system through the ringer. Besides Valsalva, we test heart rate variation to deep breathing. Literally having a patient take 6 deep breaths a minute lets us precisely measure vagus nerve health. We use tilt table testing for orthostatic intolerance, tracking arterial waveforms as a patient is tilted upright. We use QSART, the quantitative pseudomotor axon reflex test, which measures regional sweating to see if the sympathetic postganglionic axons are firing. We can even take a tiny 3mm punch biopsy of the skin to physically count the axonal densities of these microscopic unmyelinated nerve fibers.
These tools are absolutely vital, which brings us to our final stop, Section 5, when the autopilot fails. Because when this tightly integrated system breaks down, the clinical reality is devastating.
One of the most dangerous failures in orthostatic intolerance diagnostics is neurogenic orthostatic hypotension, or NOH. Normally, when you stand up, boom, half a liter of blood pools in your legs due to gravity. Your sympathetic system immediately fires off norepinephrine to constrict blood vessels and increase your heart rate so you don't just pass out. But in NOH, that peripheral norepinephrine release totally fails. The patient experiences a sustained drop in systolic blood pressure of 20 points or more without the necessary compensatory heart rate spike. They stand up, their blood pressure plummets, their brain loses perfusion, and they collapse.
And NOH isn't just a few dizzy spells, it is incredibly dangerous. It carries severe mortality risks, approaching 44% over just 30 months and exceeding 60% over 10 years. Because the stakes are that high, doctors use a simple but brilliant mathematical ratio to catch it. They divide the change in heart rate by the fall in systolic blood pressure. This gives them a clear marker of cardiac baroreflex gain. If that delta HR over delta SBP ratio is less than 0.5, it accurately points straight to neurogenic orthostatic hypotension.
Another major form of autopilot failure is POTS, or postural orthostatic tachycardia syndrome. In this condition, the blood pressure might not necessarily plummet, but the heart rate skyrockets by 30 beats per minute or more just from the act of standing up. We see this incredibly commonly in young women between 15 and 45. They suffer from this terrible combination of cerebral hypoperfusion, giving them severe brain fog and lightheadedness, mixed with massive sympathetic overactivity, which causes racing, pounding palpitations, and chest pain. It's an exhausting reality where the body's internal balancing act is completely out of sync.
But perhaps the most profound connection in all of autonomic neurology is the spectrum of autonomic failure seen in a group of diseases called synucleinopathies. We're talking about conditions like Parkinson's disease, multiple system atrophy, dementia with Lewy bodies, and primary autonomic failure. These are caused by the toxic accumulation of a misfolded protein called phosphorylated alpha-synuclein. But the field goes even deeper into peripheral autonomic neuropathies, like amyloidosis, autoimmune autonomic ganglionopathy, or AAG. And we're even seeing amazing breakthroughs like HATTR gene silencing therapies. Historically, we always thought of things like Parkinson's as purely a brain disease, but pathologically, this misfolded protein aggregates in both the central nervous system and the peripheral autonomic nervous system. In fact, the autonomic failure, like severe NOH, often shows up years before the brain symptoms ever do. This realization has led to an absolute biomarker revolution. Remember those skin biopsies we talked about earlier? Well, by using advanced seed amplification assays on a simple skin punch biopsy, doctors can actually demonstrate phosphorylated alpha-synuclein inclusions hiding right there in the postganglionic sympathetic nerve fibers. We can literally see the exact misfolded proteins that cause major central brain diseases just by looking at a tiny pinch of skin from a patient's leg. It's mind-blowing.
Which leaves us with this incredible, provocative thought to conclude our investigation today. If the very same toxic proteins that destroy the brain are also destroying the peripheral autonomic nerves, and if our skin holds the clues to the brain's deepest mysteries, could early detection in the skin and treating the peripheral nervous system one day be the key to curing the central nervous system? The human body is a masterfully interconnected web, and the more we investigate our invisible autopilot, the closer we get to unlocking the secrets of disease itself. Thanks for joining me on this explainer, and keep asking the big questions.